Hello, good afternoon, everybody. My name is Dr. Adnan Al-Sheikh. I'm a pediatric endocrinologist and professor of pediatrics in National Guard Hospital, Jeddah, and in King Saud University for Health Science in Jeddah. I will be sharing and moderating this session titled Clinical Practice Symposium, Diabetes. So we will have 4 speakers. The first speaker will be Prof. Karen Dipfort. Prof. Karen is a professor of pediatric endocrinology and diabetes. She had her pediatric training in Netherlands, Luxembourg, and France, followed by the pediatric endocrinology and diabetes training. She created a multidisciplinary team taking care of children and adolescents with diabetes. And Karen published more than 160 peer-reviewed papers published in respectful journals and several chapters in the pediatric diabetes books. Karen currently is the president of ISPAD, the International Society for Pediatric and Adolescent Diabetes, since 2020. And I must say that Karen really contributing a lot to the academic and endocrine and diabetes activities in the Gulf and the Arab region, with very valuable contribution by coming physically and sharing her knowledge and experience in many of the conferences that was moderated and organized by the ASPID Society. And she contributed very valuably to the ASPID schools in the Arab region under the umbrella of ASPID Society over the last many years. Karen just promoted as a professor of pediatric and endocrinology in the University of Luxembourg. Let's welcome Prof. Karen Dipfort. Her presentation is titled Transition of Diabetes Care from Pediatrics to Adults. Welcome, Prof. Karen Dipfort.
Dear colleagues, first of all, I would like to thank the organizers for inviting me. In this topic, I would like to discuss with you the transition of children with a chronic condition, diabetes, from pediatric to adult care. And I think those who are attending this talk, I hope that there are quite some also from the adult care present in order to hear and share experience from their perspective. I do think from the pediatric side, we still see it as a slippery slope. I'm Corinne de Beaufort. I'm based in Luxembourg and the current president of the unique International Society for Pediatric, Adolescent and Young Adult Diabetes. Transitioning from pediatric to adult care with any chronic condition, I don't think that in the end we can have one model fit all. But I think we do have a certain number of considerations to make in order to make it as smooth and good as possible. If we talk about diabetes, I think we should keep in mind our treatment targets at all moments in all age groups. We need to ensure that we strive for a good metabolic control. For ISPAD, it would be an HbA1c below 7% for WHO. It is to obtain in a majority of your population with diabetes an HbA1c below 8%. And of course, we need to observe that physical and psychosocial development is normal, that we achieve and that we achieve for our patients, with our patients, a good quality of life, and try to prevent acute and late complications. A good metabolic control is important. And I think you're all aware of the DCCT outcome, even more than 25 years after its initiation, we still see a persistent effect of those who had a better metabolic control. And I don't think we really can speak about good metabolic control, and certainly not when we look at the adolescent population in the DCCT study. But you see that the effect remains a very long time afterwards. Key in diabetes is, of course, insulin, access to insulin, insulin delivery, glucose monitoring, and education. Without education, insulin and glucose monitoring are not going to be very effective. But education should be adjusted to age, culture, and it should be ongoing. We can't stop after having started it. For us pediatricians, it will start with family and the young person, the very young person, the child. Parents will be our first focus together with the child. But we shouldn't forget that the child turns into an adolescent and a young adult. And during that way, we need to have that ongoing education to make sure they are aware of all different things around treatment, which they need to know. Adolescence is a phase characterized by major changes. We all know, of course, physical changes, growth, sexual development, psychological maturation, social changes, and emotional changes. The role of the family will change. The peer group will be far more important. The young person will become independent instead of depending on his parents and family. And all this needs to be taken into account when we're working on the self-management of diabetes. That needs to be picked up and done by the young adolescent himself or herself. This again focuses on the fact that we really need to make sure that we've got structured self-management and that we educate that. Psychosocial factors need to be taken into account, because if you've got someone where you're working in an inappropriate way or who has major psychosocial worries, then the message we try to put across is not going to get there. And they are major factors influencing care and outcome of care. Important issues for all adolescents are their relationship with a peer. As I mentioned already, the peer pressure or influence is extremely important, but they will as well have their further development, their sexual maturation and sexuality issues, identity issues, or challenges. Eating patterns, always something we have to consider, certainly in young people with diabetes, where already there is a focus on food and the calculation around carbs, and so on and so forth. The slope towards eating disorders or abnormal eating patterns is close, and we need to be aware of it. Risk taking is part of getting an adolescent or being an adolescent, which brings them as well closer to substance use and abuse, accident and injury risks and prevention we need to address and need to consider. Mental health issues are very important in the turmoil of things which are ongoing. And let's not forget that after the 2 years, of COVID pandemic and restrictions in being in contact with your peer group have had a huge impact on a lot of adolescents and on a lot of people in general. So I think we need to be very careful and very attentive in seeing when we get signals that we need to go into more detail with these potential issues. In adolescence, you need to address as well the issues around your future, your education, your occupation, and in what way a chronic condition might hamper your wishes or your dreams. Having access to support groups will be something very important. And then, of course, we talk about adolescents as a group. Here you've got a lot of them. Let's not forget that these are hundreds of people with all very different characters and needs. What happens if there is non-adherence during this phase and in a chronic disease? You get treatment failure. You get a decreased quality of life in diabetes based on a roller coaster of blood glucose variations. There is an increased risk for chronic complications and an increase in the healthcare utilization. So the transfer of the medical care from child-centered healthcare in the middle of this chaotic period to adult-oriented healthcare is not an easy task. Transition should be, ideally, seamless, coordinated, appropriate for development, psychologically sound, and it should be continuous. It should guarantee that continuity of medical care, psychological care, should provide a good quality of life for the young person with a chronic condition. And very important, we should prevent opting out or dropping out of care, because the population dropping out of care at that time might reappear in adult care with complications. And these might or might not be reversible. Now, what are the requirements, whether at the pediatric or the adult side? If you've got adolescents with complex health needs, we need to have an adolescent appropriate, friendly service. We need to have continuity of care, multidisciplinary teams, preferably. It should be, again, appropriate for the age and the development. It should have sufficient technical facilities. The attitude should be empathetic and absolutely culturally competent. And then if you look at the difference by general approach in pediatrics versus adult, the pediatric teams are family focused because they're confronted always with the family and rarely with the adolescent alone. They should be friendly. Oh, we think we're very nice and friendly. Don't know whether all adolescents consider it the same. And let's not forget, usually we know the youngsters for a long time, from when they were very small and started with their disease. And we've grown up a little bit with them. We know the families, we know the family interaction. We have got very often that paternalistic or maternalistic approach, whereas in adult teams, there is a difference. There is expected autonomy of the patient. He or she should be independent. There is less personal contact and larger patient numbers. And if there is non-compliance of the person with diabetes, that's not anymore considered very often a problem of the healthcare provider. Now, how can we address transition? I mean, there are quite a lot of papers addressing it from different perspectives. A paper of Rapley saying, okay, enough of the problem, and the review of the time for healthcare transition solutions for young adults in general with a chronic condition. There's another paper addressing the barriers and the facilitators, whether young people and young adults attend hospital diabetes clinics or not. And here you can see young adults is considered between 15 and 30, whereas I would say youth is 15 to 24, 25. And maybe I would not always call them young adults. There's a Cochrane analysis, again, from general chronic conditions transition, very limited data, which are robust enough really to analyze, to come and generate a best practice approach. There is the experience of the adolescents with type 1 diabetes and their view on what should be done. This is a recent paper. And there is the adult care providers' perspective. What do they expect from those young adults or adolescents or youth coming to their clinic? I think there still is quite sufficient scope for a rigorous evaluation of what we're doing and what the different models are bringing. One vision, I think, which needs to be included, and there everybody probably agrees, is the fact that we need the input and the attitude towards transition of the young person himself, of the adolescent. If they consider they are ready for transition, I think we should listen. And this is based, again, on a general group of adolescents with chronic conditions and a web-based questionnaire, but really a key message. So timing of transition. Again, if we are looking at the attitude and the readiness of the young person, we should include them in that timing and prepare them for the timing. We should know their perception, and we should prepare their perception of moving from pediatric to adult care. We should prepare them for it. We should prepare them and their families just as much. On the other side, we should know what the outcomes are post-transition in order to improve the way transition is done, and the perception on the other side might be on the other side, the same side of care, but on the adult team. Identify barriers to the transition and facilitating factors to transition should be taken into consideration to optimize this period. Now, very pragmatic is what age should it occur, and when should we start to prepare our patients with diabetes, and how should we prepare them, and can we evaluate it, and how can we evaluate it? I think the latter is really important, because only then we can move forward and establish best practice, even if that best practice might not be the same in different cultures and different regions around the world. So what age should it occur? I think it should be flexible, and the data suggests that maybe you shouldn't have a fixed chronological age. In the past, it might have been 12, it might have been 16 or 18. I think it should depend on the perception of the adolescent and his or her readiness to move on. And it should be probably flexible between 18 and 25 years. So when should we start to prepare? And I think there are some clinics working or groups working a lot in these fields, as the Canadians and some of the UK groups. They suggest really to start early. Start already at 12 years. Like education in schools, you have to start early in order to achieve sufficient knowledge and readiness when children leave school, but as well when they leave their pediatric care team. That doesn't mean that they have to be ready at 12, but you start discussing it. And of course, there is an influence of the local setting, and whether in a local setting, children of 12 to 18 or adolescents can still be cared for by the pediatric team. Who should be involved? Of course, the adolescents. Primary care physicians should be involved in transition, probably as well, because if young people drop out, then the primary care physician might be the one who is expected to take over that phase. Pediatricians, subspecialists, adult subspecialists, and members of the multidisciplinary team. I think it's important as well to include the family members, because parents very often are worried as well for the transition, and the service commissioners. It should be done in teamwork. So a lot will depend on the local setting. Optimally, everything would be gradual, and if a close collaboration exists between adult and pediatric diabetologists, this definitely is an option. And it can be done as well when a nurse can act as a case manager and be between the two, be the link between the two teams. Sometimes it's acute in some regions around the world. You've got a sort of market where all the adult endocrinologists are there, as well as those young people who are transiting care, and they can discuss with the different adult physicians how their approach is and identify best fit. Or there is no transition at all. In some clinics, they've organized either an internal medicine endocrinologist in their team, and they continue to care for children from 0 to 100. I think it is nice to have that shared consultation in the pediatric clinic, or to have a shared consultation in the adult clinic. When they are well prepared, that will facilitate the transition. In some regions, there will be a web-based preparation with very specific dedicated programs. And I think in Australia, there have been several experiences with this approach. So very important, I think that's one of the key points of success, is to prevent dropouts and those who are opting out of care. I think the gradual change with combined clinics would be the ideal situation. and or a longer follow-up with a case manager if you've got different clinics, where there is a check after 6 months and 1 year to see whether going to the clinic has been continued. It's essential that there are discussions between the different teams working in the same field, but with different age groups. So transition from pediatric to adult care should be having as well and be characterized by a harmonized approach. This harmonization shouldn't be an identical type of care because we do things different, but at least we should have a harmonized way of conveying the message. Very important to have written information for the adult team and provide that as well to the patient, that he can move to another team if there is not an optimal fit. It is good, I think very good, to have a case manager who can check after transition and have that maybe ongoing for a longer period of time. So my take-home messages on the transition is that there shouldn't be a rigid age. There is no perfect method. One model fits all, but it should be made to measure, to the region, to the person. And I think the most important thing we should consider is that there is continuity in care. There are a harmonization of the approaches, that we've got written summaries for teams and patients, and a longer follow-up, if possible, after the transition. I thank you for your attention. Teamwork on a boat in the Netherlands by young people with diabetes, and teamwork for all the people working around the transition of young people moving into adult care.
Thank you, Prof. Karen. Very interesting presentation, and thank you for sharing your experience. We will delay the questions until the end of the 4 sessions. So the next speaker will be Dr. Abdulhadi Habib. Dr. Abdulhadi Habib is a consultant pediatric endocrinologist, and he's the chairman of Pediatrics at National Guard Hospital in Medina al-Munawwara in Saudi Arabia. And he's also the ASPID Secretary General. Dr. Abdulhadi was trained and practiced in the UK for the last 15 years before he moved to Al-Medina al-Munawwara in 2007. And also he is a fellow and examiner for the UK Royal College of Pediatrics and Child Health, and a coordinator of the ASPID SP Endocrine Academy. Dr. Abdulhadi Habib main research and interest is monogenic diabetes, and recently he became an associate editor for the Journal of Pediatric Genetics. Dr. Abdulhadi Habib has a valuable contribution in the research of monogenic diabetes and neonatal diabetes in the Arab region, and also he has a very respectful and strong research on DKA prevalence in Al-Medina region in Saudi Arabia. Dr. Abdulhadi is really a very good speaker in many of the regional and international conferences, and his topic today will be on monogenic diabetes. Welcome, Dr. Abdulhadi.
Good afternoon, everybody, and thank you very much, Adnan, for the introduction, and congratulations for the new promotion, as we heard in the couple of hours that you've been promoted to be a professor of pediatrics in National Guard, Jeddah. Now, I would also like to thank the organizing committee for the Gulf Association for Endocrine and Diabetes for inviting me to contribute for this meeting. I was given the task of covering monogenic diabetes, and I think this is a very broad subject, as you know, so I'm going to just focus on the following points, and starting with what we mean by monogenic diabetes. I will go through the causes and subtypes quickly, and then I will try to find out if we have any good evidence of how common the condition is. And then I will discuss with you why and how to diagnose monogenic diabetes, and will share with you some clinical cases which illustrated the benefit of diagnosing monogenic diabetes and the utility of genetic testing in diabetes in general. And then I have 1 or 2 slides on future perspective in monogenic diabetes before I conclude. Now, before that, let me just share with you this young man, which I would say triggered my interest in this interesting condition, or in monogenic diabetes in general. And this boy was referred to me at the age of 7 years with asymptomatic hyperglycemia for 3 months. And the reason for detecting this is that the father has diabetes and the grandmother also has diabetes and died at in her early 50s with diabetes complications. So the mother kept testing all her 3 kids, and this boy showed evidence of high blood sugar. She tested his urine. It was also positive, but there was no ketonuria. His BMI was fine. He had no evidence of insulin resistance, such as ketosis nigricans and overweight. His hemoglobin A1C was slightly high, 7.1. He was seen by the father's physician who looks after the dad. And as I said, the dad was diagnosed at the age of 33 years with type 1 diabetes. And interestingly, he had evidence of retinopathy at the diagnosis. So it wasn't really typical for type 1 diabetes. So the adult physician did glucose tolerance test, which showed or confirmed the presence of diabetes with a glucose of 21.7 at 120 minutes. The family were given some dietary advice, and the child was started on a small dose glargine, with a review later showed no improvement. A1C was going up, and his blood glucose was also high, though he remained very asymptomatic. He was referred to my clinic, and on further assessment, he showed no pancreatic feature. He's had normal C-peptides and negative pancreatic autoantibodies. And I think at this stage, you would ask yourself whether this is a type 1 diabetes in the prodromal stage, but he had no autoantibodies. You would think about type 2 diabetes, given the history of the father and the grandmother, but I mean, the child didn't really have enough evidence of that, and that his A1, his BMI was within the normal range. And because of the family history and the fact that he had no autoantibodies, then you would think about the possibility of maturity onset diabetes of the young. But he is very early for this condition. And indeed, we sequenced his hepatic nuclear factor 1 alpha gene and confirmed the diagnosis of MODY3, both in the child and his father. Now, based on that, we changed his medication to small dose gliclazide, and you can see his A1C dropped down beautifully to reach 6.2 at 18 months of age. So making the right diagnosis for this child not only helped his clinical management, but also helped in identifying the father's type of diagnosis and management as well. And unfortunately, not all children or people with monogenic diabetes just have this condition. It is a heterogeneous condition, and you can see here there are at least 50 genes now in which mutation can lead to different forms of monogenic diabetes through different mechanisms. The genes in the blue box here, they control the beta cell function and structure, and if you have mutation in that, you get conditions like maturity onset diabetes of the young, neonatal diabetes, and a number of syndromic monogenic diabetes, as well as mitochondrial diabetes. Now, the genes in the pink here are involved in the insulin signaling and the insulin receptor as well. So if you have mutation in these genes, you will get syndromes of insulin resistance. Now, there's a number of genes here I stated in the yellow box, and these genes are involved or important for the control of the pancreatic immune system. So if you get a defect in these genes or mutation in any of these genes, you get conditions associated with autoimmune diabetes, but they actually have monogenic origin, and that's what we call monogenic autoimmunity. And the best example for that is the autoimmune polyglandular syndrome, IPEX, and other IPEX-like syndrome. So it is a heterogeneous condition, and I think when you look at the epidemiology, this is probably the largest study looking into the prevalence or the frequency of monogenic diabetes. And as you can see, the children's referred to 15 Italian pediatric diabetes centers were tested for the presence of monogenic diabetes, and this came out with a very good figure, 6.3% of the cases, and the majority of these patients got MODY, followed by neonatal diabetes and a number of monogenic or syndromic diabetes. And people talk about the prevalence or the high emerging of type 2 diabetes, and here you can see the type 2 diabetes was actually less prevalent or less frequent than monogenic diabetes, at least in this cohort. We do not really have any data from the Middle East or the Gulf region, but what in the prevalence of monogenic diabetes in general, but what we know is the Gulf region has the highest incidence of neonatal diabetes mellitus worldwide, and the reported incidence both in Saudi Arabia and the United Arab Emirates is 5 times the highest frequency reported figures from Europe and the USA. So how we make the diagnosis of monogenic diabetes? I mean, it's very difficult really to summarize this up because this is a heterogeneous condition, but we usually try to identify patients with high susceptibility or high possibility of having monogenic diabetes. And this includes any patients with any of the following, either those who diagnosed in the first 6 months of life, or maybe say 9 months of life, those who have mild stable fasting hyperglycemia with extra pancreatic feature, antibody negative, and family history of diabetes without the typical features of type 1 and type 2 diabetes. And out of these, you can the next step is to take them for genetic testing. And if you have really very clear characterization of the phenotype, then you can do direct sequencing of just a single gene, and this probably much cheaper and quicker. Or you can ask for the multi-gene panel using the next generation sequencing, which is overall works out cheaper because you're going to test a number of genes, and in fact, the 50 genes I showed you in the first slide can nowadays be tested in one go using this technique. Or if you got a lot of money and time, you can use the whole exome sequencing. So why we really bother about making the diagnosis? And I think the first thing is making this diagnosis will allow us to use the best treatment or select the best appropriate treatment or management in general for the patient. And I showed you in the first slide example of that, and I'm going to take you through some examples as we go on. It can correct the diagnosis of other family members, and we've seen that also in the patient I showed you. It can enable the genetic counseling, and I'll show you that, explain other associated features. We'll show this in a number of cases, and it can predict the clinical course of the disease because some of these forms of monogenic diabetes have very mild, stable course that doesn't need treatment. And of course, it has a lot of scientific evidence or scientific benefit because knowledge of rare conditions can help us really understand the mechanism of disease of more common conditions. Let me start with this young girl who is the product of consanguineous parents. She was born at term, normal delivery, normal birth weight, and at the age of 4 weeks, she presented, or she was found to have a very low hemoglobin and platelet. She was given blood transfusion, and 2 weeks later, she developed diabetes. The parents insisted that the transfusion has resulted in the diabetes. Then she was referred to a higher center where she needed 9 transfusions in 1 year. She also had 3 bone marrow biopsies. All of them were inconclusive. And as the parents fed up, they requested a follow-up in Medina, which is closer to their town. We saw them in our combined endocrine hematology clinic at the age of 13 months, and she was on a relatively good dose of insulin, but her A1C was high at 10.2. She continued to be anemic and thrombocytopenic despite frequent transfusion. Her MCV was within the normal range, and I'll tell you why this. So we thought about a condition called thiamine-responsive megaloblastic anemia, and typically this condition have a high MCV. So we're not really sure, but our hematologist said because she had a lot of blood transfusion, this can affect the MCV. We also asked the family whether they have any concern about hearing, and they thought the child hears them. But despite that, we went ahead. We requested hearing test, which confirmed bilateral sensorineural deafness, and we also requested a direct sequencing of the SLS19A2 gene, which is known to cause this condition or link it to this condition, and that confirmed the diagnosis. So we added thiamine to her insulin, and we fitted her with hearing aids. And this is her hemoglobin A1C after 18 months from starting the thiamine, and you can see here that her A1C beautifully came down to a very acceptable level since we started the thiamine. And this was associated with a significant reduction of her insulin dose up to 60%. She had no further blood transfusion. She's now 10 years and she had no further blood transfusion since we introduced the thiamine. And her speech is fine, but still needing hearing aids. We gave the family some counseling, and we told them about the future risk of having a child with similar condition, but despite that, they were motivated enough to go ahead. They had another child, and again, we asked them if they have any child, please check the blood glucose and the hemoglobin as early as possible. And as you can see, the hemoglobin was just a photocopy of her sister, but she was completely asymptomatic. And because the diagnosis was discovered early, we started her on 100 milligrams of thiamine at this age, and she continued nicely. Now at the age of 6 years, she was just on thiamine only. She did not need any insulin. Her hemoglobin was fine, platelet is okay, normocytic, A1C is better than mine. She got a normal hearing and speech, and her score performance was fine. And I think this is another illustration of the importance of making the right diagnosis and doing the genetic testing. It predicted the occurrence of the thiamine-responsive megaloblastic anemia in the family, and this enabled us to select the right treatment at the right time. It prevented the deafness and avoided the insulin so far. And this is a very interesting condition. It's not that common, but as the name suggests, it's a combination of anemia, deafness, and diabetes. Some patients have also minor features such as thrombocytopenia, short stature, cardiac and visual defect, as well as CNS anomalies. Now, it is caused by mutations or biallelic mutation or homozygous mutations in the SLS19A2 gene, which encodes the thiamine transporter protein 1. So these patients have a defect of getting the thiamine inside the cells rather than the amount of the thiamine in the blood, where if you really measure the thiamine in the serum or in the blood in general, it will be normal. And this is just to try to simplify what happened in this condition. Here we got the thiamine, which is important for the formation of the thiamine pyrophosphate transporter, which is a cofactor for a number of enzymes in the cellular metabolism. And in order to function, it has to be taken inside the cell using these two transporter 1 and 2. 1 is encoded by the SLC19A2 gene, which is expressed in all tissues. And there is another gene encoding the thiamine transporter 2 transporter number 2, which is SLC19A3, and this gene is not expressed in the beta cell, bone marrow, and inner cell. If you have a lot of thiamine in the blood, it can really go inside the cells using the passive diffusion, so regardless of this of these transporter. Now, so in this condition, you got a defect in this gene, so you only have the thymine transporter 2 to get the thymine inside the cell, and we know this is not expressed in the beta cell, marrow, and inner cell, and that's why patients with this condition they have a problem in the pancreas, bone marrow, and the inner cells. But if you give a lot of exogenous thiamine, then it can diffuse and bypass all these things and improve the situation. We recently looked at the phenotype and genotype and the response to thiamine in a number of patients from 16 countries. And as you can see here, all these patients, or the majority of these patients, responded or improved by adding the thiamine. And in fact, 4 of them became completely insulin independent after starting the thiamine. And it seems that the earlier the treatment, the better the diagnosis, or the better the impact of the insulin production or the insulin requirement. Now, let us move to another form of neonatal monogenic diabetes, and this is a term baby born to unrelated parents, unlike the previous one. And at the age of 6 weeks, he presented with poor feeding, vomiting, and weight loss. As you can see here, he's really very skinny. And when he came, he was on a typical diabetic ketoacidosis. A1C was 10.1. He started on insulin after managing the diabetic ketoacidosis. At the age of 1 year, he continued to fail to thrive. He's got frequent DKA on the way, started to show evidence of neurological problems in forms of hypotonia and developmental delay. And at that time, his insulin was respectively good, but his A1C was very high. His C-peptide was also unmeasurable. We measured we tested him for the KCNJ11 mutation, which is part of the potassium ATP channels mutation, and he was positive for heterozygous KCNJ mutation, and at that time his hemoglobin A1C was 10, and you can see here when we introduced the sulfonylurea, his hemoglobin A1C improved, and he remained, and by 2 months of age, he remained on just hemoglobin A1C. At 6 months, he was doing fine on relatively large dose of sulfonylurea. His A1C was very respectable, 6.2, start to thriving, his development was better, and he was able to produce some C-peptide. And the potassium ATP channel mutation is the commonest forms or the commonest cause of neonatal diabetes, but I have to emphasize that this is in non-consanguineous parents. So it is not really the commonest cause of neonatal diabetes in our part of the world or in population where the consanguinity rate is high, and I'll show you evidence of that. It can cause permanent or transient neonatal diabetes. It's typically autosomal dominant, but the majority of the cases are sporadic due to de novo mutation. And as I show you in the previous patient, some of these patients have developmental delay, epilepsy, and neonatal diabetes, and which called Down syndrome. The good news is the majority of these patients can secrete insulin in response to oral sulfonylurea, as we've seen in the patient I presented. And this is just to try to explain it quickly. This is a cartoon showing the beta cell, and we know that the glucose enters the cell and get metabolized in the mitochondria with the result of rise in the ATP compared to the ADP. And it is the rise in the ATP which really close the potassium ATP channels. And there are 2 subunits here, the clear 6.2 encoded by KCNJ11 and the sulfonylurea 1 encoded by the APCC8 gene. And as a result of closing the ATP channel, then you depolarize the membrane, influx of calcium inside the cell, which secrete or relieve the insulin from the insulin granule. So if you just imagine here, if you got a mutation in this, then this will not happen. If you give sulfonylurea, it will close the potassium ATP channel by completely independent mechanism to the ATP, and as a result, you have secretion of insulin and improvement in the A1C. And this has been showed really in a lot of data or a lot of studies. These are the first 2 studies, I'd say, which shows the the impact of switching from insulin to oral sulfonylurea in patients with diabetes due to potassium ATP channel. And if you ask me what is the breakthrough in pediatric diabetes over the last 20 years, I would say the ability of managing patients or switching patients from insulin to sulfonylurea. And they don't just respond well to the sulfonylurea. In fact, they get a better response by the improvement in their A1C. And as a result of these studies and others, the recommendation was to any patients, or regardless of their age, who presented with diabetes in the first 6 months of life should be tested for these mutations and others, and to be given a trial of oral sulfonylurea. And this is what we've been doing, but unfortunately, we found no potassium ATP channel mutation in our cohort of 17 patients who were followed up or diagnosed over a period of 10 years. But this is an old study, it's nearly 10 years. I can't really imagine how the time is passing so fast. So we had other patients recently, but I think we need to repeat that. Right, but this raised the question whether permanent neonatal diabetes is different in Arab compared to European and North American. And in fact, we confirmed that as you can see here, yes, there was some potassium ATP channel mutations in the Arab cohort compared to the British cohort in the sky blue. But in our cohort, we found that Wilcox-Rallison syndrome due to EF2AK3 mutation is the commonest cause of permanent neonatal diabetes in Arab. So there is a different etiology in this part of the world compared to Europe and North America, where potassium ATP channels are the commonest. This is the typical look of child with Wilcox-Rallison syndrome, which is the commonest cause of neonatal diabetes in our region. And as you can see, they got skeletal deformities, got diabetes, they got skeletal dysplasia, fragmentation, both of the vertebra, the metacarpal bones, as well as the femoral head. And this is not the main problem. The major problem is the majority of these patients have liver defect and die of severe fulminant hepatitis. And in fact, one of our patients, this is just a cohort from 8 Arab countries, and you can see the majority of these patients, all of them have diabetes, but the majority have liver disease, which is more frequent than the skeletal dysplasia, which is thought to be one of the major criteria of the disease. The good news is one of these patients really underwent liver transplantation and improved as a result of that, at least as far as the liver is concerned. And the liver transplantation and the organ transplantation in general provided a new hope. There are at least now 4 publications, not just on liver transplantation, but some of these patients got multi-organ transplantation, including liver, pancreas, and kidney. And as you can see here, most of them became off insulin and had no further hepatitis. Now, what else can we do for these patients? This is a data from Asma Deeb's group, and you can see here, this is a very big family with Wilcox-Rallison syndrome from United Arab Emirates. And as a result of using the pre-gestational diagnosis, the family were able to have a healthy child using this technique. So if you don't really have the facility to correct the diagnosis or cure the condition, you can at least provide them with some help. Now, let me end up with this young man who was 8 years old when he was referred to our clinic with nocturnal enuresis. And just routinely, his blood sugar was measured and was high, 8 millimoles. Postprandial went up to 9.8. He's got no glucosuria. He has hemoglobin A1C borderline, normal weight, no acanthosis, negative autoantibodies. Similar to the first patient I showed you in the presentation, but the parents were not diabetic and the blood glucose was not really high. And based on that, we sequenced the glucokinase gene and identified a de novo heterozygous mutation confirming the diagnosis of MODY2. And this is a very mild condition, and it's really an example of where the just diet control alone will help in maintaining the blood glucose for these patients. And just to remind you that the glucokinase is the gene, is the glucose sensing gene, which tells the beta cell how much insulin it should produce. So these patients, they just have their thermostat, if you'd like, just set up a little bit higher than non-diabetic. They can produce insulin, but they really need to have a higher blood glucose. So instead of 6 and 7, you need it really to be around 9 and 8 to secrete insulin. So maturity onset diabetes of the young, or MODY, is, as I said earlier, is the commonest form of monogenic diabetes. It's an autosomal dominant, but can occur as a sporadic case, as we've seen in this patient. Typically, patients present during early adulthood, just before the age of 25, but they can present very early on, typically non-ketotic diabetes. A lot of diabetics nowadays are raised as or diagnosed as type 2, but mind you, you can have MODY with diabetes, and there are a couple of case reports at least with MODY and diabetes. And MODY is not just one condition, it's a heterogeneous condition. This is a very nice systematic review published last year, and it showed you so far we got 14 different forms of MODY. Of course, we're not going to go through them, but I showed you the last patient I showed you was MODY 2. They usually present in the pre-adolescent stage, and as you can see, mild hyperglycemia, excellent prognosis, no treatment is needed, at least during childhood. And the one I showed you earlier is the commonest form of MODY, MODY 3, hepatic nuclear factor 1 alpha, usually present around adolescents. They have high risk of microvascular complication. If you remember, the father of the first child is got retinopathy at the diagnosis. They got low glucose threshold, i.e. they have glucosuria at a relatively low glucose level, and you can really manage them at least for a good number of years using the sulfonylurea alone. So what is the future caring for us in terms of monogenic diabetes? I think it is expected with the availability of genetic testing that more genetic causes will be identified, and more patients will be diagnosed, and maybe these patients were either misdiagnosed or undiagnosed with other forms of diabetes. The other point I'd like you to be aware of, that we are moving, I think, into the era of considering routine screening for monogenic diabetes, not just in the diabetes clinics, but also as part of newborn screening program, particularly in areas where neonatal diabetes is high. This is a very nice study published 2 years ago from an Australian group looking at the cost effectiveness of the routine screening versus selected screening for maturity onset diabetes of the young in a pediatric diabetes cohort, and and using the parallel sequencing, i.e. the multiple gene sequencing. They looked at the cost of the genetic testing, the cost of the using insulin versus sulfonylurea, because as a result, because if you really made the diagnosis of the commonest form neonatal of MODY, then you can use sulfonylurea rather than insulin, and the need for follow-up, complication, and the quality of life. And to my surprise, there was a good health benefit of the routine screening or the genetic screening within the first year, and this has really improved or offset again within the following 10 years. And this routine screening reduced the healthcare cost by a good amount of money over 30 years. And most of these improvement or the benefit were in the quality of life and the use of sulfonylurea rather than insulin. And the group raised the argument for routine genetic screening in all children with presumed type 1. And I think with the availability and the lower cost of genetic testing, I think we are moving into that. Another way of screening is screening for neonatal diabetes in using the dried blood spot glucose measurement on day 5 of life. And there is a very nice preliminary study showing that patients with neonatal diabetes, or a number of patients with neonatal diabetes, even though they present later during infancy, they are actually showing evidence of hyperglycemia when they looked at their dried blood spot. So in conclusion, monogenic diabetes is a heterogeneous condition. It's caused by mutation in more than 50 genes. Yes, it is rare, but it could be underdiagnosed. Even though the condition is rare, I think making the diagnosis can influence the clinical management, and I hope I showed you some evidence of that. And I think the screening for monogenic diabetes sometimes in pediatric clinics could be a routine practice in the near future. And with this, I'd like to thank you, and I'd like to thank all my colleagues who helped me in putting all these data I showed you together, not just from the Middle East, but from Europe. And I also would like to my colleagues in particular in the Maternity and Children Hospital in Medina, the National Guard, and the ASPED group. And I will also like to thank the Wellcome Trust for supporting most of our work. Thank you very much.
Thank you, Dr. Abdulhadi. That was a valuable presentation, sharing your experience and research in the Gulf region in the monogenic diabetes. And we will keep the question till the end of the session. So we will move to the third speaker. The third speaker is Dr. Saif Al-Ya'rubi. Dr. Saif is an associate professor of pediatric endocrinology in Sultan Qaboos University, and he is also the assistant executive president for International Cooperation Department and Oman Medical Specialty Board. Dr. Saif graduated from the College of Medicine in Sultan Qaboos University, and then he joined McGill University to do the pediatric residency training and the fellowship in pediatric endocrine in Montreal, Canada. Dr. Saif has published more than 50 peer-reviewed articles in highly indexed journal, and he is also one of the editorial board of Oman Medical Journal. Dr. Saif was elected to be the first president of Oman Pediatric Society, and also the vice president of Oman Diabetes Association for 4 years. And he was appointed as the assistant executive president for international cooperation. Dr. Saif also oversees and organizes the training of Omani residents and fellows abroad. Dr. Saif presented many local and international presentation in conferences and workshop, and his topic today is lipodystrophy. Let's welcome Dr. Saif.
Thank you, Prof. Adnan, and congratulations for your recent promotions. We are all happy for you in the Gulf, and hopefully we will get more professors soon. I was given the task to present lipodystrophy in the coming 25 to 30 minutes. It's a huge topic. I will try my best to review the topic and give you an insight of it. I want to thank the organizing committee also to allow me to participate with you today. I have no conflict of interest. The objective of my presentation is to review lipodystrophy in general, talk about the clinical manifestations and the treatment options, our experience in Oman and the region quickly, and then some take-home messages. So lipodystrophy syndrome is a rare disorder. It's ultra rare, actually. It's not curable. And the global prevalence of lipodystrophy in the world is between 1.3 to 4.7 cases per million. But our understanding to this disease in the Gulf region that we have many cases undiagnosed. So I don't think this prevalence work with us, and I think we have a higher prevalence than this in the Gulf and the Arab world. It's basically a selective deficiency of adipose tissue in the absence of nutritional deprivation or a catabolic status. And this will result in a low or extremely low level of leptin. And the leptin is the culprit of most of the comorbidity which happens in lipodystrophy. So lipodystrophy is a complex metabolic disorder characterized by regional or generalized loss of adipose tissue. And this will result in deficiency of the hormone leptin, because hormone leptin is secreted mainly from the white adipose tissue. And leptin is really the important hormone, one of the important hormones for energy homeostasis and metabolic function. So as a result of leptin deficiency, it carries a lot of risk to the metabolic status of the patients. They usually have insulin resistance, hypertriglyceridemia, they develop type 2 diabetes mellitus, and also because of the leptin role in appetite, they have huge appetite, and they also get chronic fatigue. The other problem with lipodystrophy is because the adipose tissue is the storage is not there. There will be an ectopic fat deposition in the organs, liver, muscle, and other organs, and this will cause serious organ damage. Lipodystrophy is divided into 4 main categories, and this is based on 2 things: in the etiology, if it's congenital or acquired, and also based on the distribution of lost adipose tissue. And because of this characteristic, this will yield to 4 categories: congenital generalized lipodystrophy, familial partial lipodystrophy, acquired generalized lipodystrophy, and acquired partial lipodystrophy. There are other forms of lipodystrophy related to other disorders, syndromes, and also acquired causes like progeroid disorder and autoinflammatory disorders. But before we talk about lipodystrophy, I think we need to review the adipose tissue and the hormone leptin, because it's really important to understand the pathophysiology of lipodystrophy to understand the treatment options and the different types of lipodystrophies. So as you know, adipose tissue is a vital organ of a complex network, and it participates in a regulation of various biological functions. And the white adipose tissue secrete many hormones, growth factors, enzymes, cytokines, complement factor, and matrix protein. And the most extensively studied of those adipokines is, to the date, is the hormone leptin. Leptin is a complex hormone with many vital roles to the body. So it's not only affect the metabolic status and the status of insulin and insulin resistant, but also it acts in the brain for food intake and energy expenditure. It regulates certain hormones in the brain. We'll talk about them in details. But it also affects the vascular functions, reproductive functions. It affects the bone maturation and bone mass, and have also an important role in the immune system modulations. There are also direct effects of leptin in organs like kidney, bowel, pancreas, and muscles. So how does leptin regulate the food intake and homeostasis, energy homeostasis? Now the literature, we know from the literature, there are many neurons in the brain which are regulated by leptin and insulin. Of those are agouti-related protein neurons and proopiomelanocortin neurons. Those two important neurons are really the target of leptin and insulin. And we think that the action of leptin in these two neurons are really what gives the appetite on those patients. So when you have a leptin deficiency and a low fat mass, which result in a low leptin, there will be a stimulation of the agouti-related protein neurons and inhibition of POMC neurons, and that will cascade certain mechanisms to increase the food intakes and increase the appetite, and then it will lead to obesity. On the other side, when you have a surplus of leptin, it will inhibit the agouti-related protein, and it will stimulate the POMC neurons, and that will also, you will feel full and you will decrease the food intake, and that's what we call it an orogenic effect, and there will be a decreased food intake and a decrease in body weight. So that's the main role of leptin centrally in the appetite. But it's also leptin regulates glucose and lipid metabolism by suppressing glucose production in the liver, suppressing glucagon secretion by pancreatic alpha cell. It inhibits insulin production and secretion, promotes glucose uptake and metabolism in the skeletal muscle. It promotes also fatty acid oxidation in the liver, skeletal muscle, and adipose tissue. So it's an important role for glucose and lipid metabolism. The role in neuroendocrine function, we know that patients with leptin issues, either leptin deficiency or leptin receptor problems, they also have delayed puberty or late onset puberty, and that's because of the regulation of leptin in the rhythmic production of gonadotropins in the brain. And also there are other effects of leptin in other hormones like thyroid function. So it increases the thyrotropin releasing hormone levels, and also increases T3 and T4 level. As we said, leptin is an important immune modulator. It stimulates neutrophil chemotaxis and promote macrophage phagocytosis. It also promotes production of pro-inflammatory cytokines like interleukin-6 and TNF-alpha factors. It also increases the production of T helper cell. Because of these actions, when you have low leptin, those patients are prone to sepsis and bacterial infections. Leptin also will modulate the bone metabolism, both centrally and peripherally, by regulating the bone formation through stimulating the hormone that affect bone remodeling, and promote the differentiation of marrow-stromal cell into osteoblasts. Leptin also will stimulate osteoblast proliferation and mineralization. Now we go into the pathophysiology of libodystrophy. How libodystrophy affects the body. So initially in the left side here, you can see the lack of adipose tissue, the lack of adipocytes from the adipose tissue will result in low leptin. The low leptin will increase the appetite centrally. It will lead to increased hyperphagia and increased calorie intake, and also it will lead to the metabolic syndrome because of the high intake of calorie and because of also effect of leptin in the glucose and lipid metabolism. So you get the metabolic syndrome. And because of the lack of the normal storage of fat will be deposited in other organs, and you will get like ectopic fat deposition in the liver, and you'll get hepatosteatosis. So this is basically the basic mechanism of libodystrophy. The more loss of fat you get, the lower the leptin, the more metabolic syndrome and ectopic deposition will happen. This is the effect in the organs. So in the muscle, there will be a decreased glucose utilization, decreased fatty acid oxidation. Centrally, we say decreased satiety, increased food intake. It affects also the liver, the heart, by increasing fatty acid in the circulation. So possibly they will get cardiomyopathy, and they get very often in the generalized type hypertension. They also, it gives you, because of deposition of fat and increase of insulin production because of the diabetes, it will lead to atrophy of the pancreas. And it also affects the reproductive functions by effect of the high insulin. So they get very often PCOS, and they can get also acromegaly feature because of high insulin and acanthosis nigricans. In the liver, they get hepatosteatosis, increased lipid synthesis, and increased glucose production. So if we replicate that to the clinical picture, they will get hyperphagia, hepatic steatosis, insulin-resistant diabetes, and reproductive dysfunction, and serious comorbidity like hypertension, heart failure, cardiac rhythm disturbances, and cardiomyopathy. They can get even liver cirrhosis, acute pancreatitis because of high TGD, and they get very often proteinuria in the generalized type, and some of them they end up with end-stage renal disease, and they get also proteinuria and nephropathies. And I think if you want to know about libodystrophy, this is a very sentinel paper and landmark paper where it was a group of experts around the world met and produced this multi-society practice guidelines. It's easy to read, and I think everybody who have a patient with libodystrophy need to read this paper. It's by Rebecca Brown in Endocrine in 2016, and I recommend it to everybody. So if you have a patient with libodystrophy, first of all, you have to have the suspicion of libodystrophy, and you need to rule out conditions that give you a catabolic status or anorexia, for example, that will lead to libodystrophy. If you ruled out a condition like that, then you look at the pattern of fat loss. Is it generalized versus partial? If it's generalized, then you go back into the history, look at family history, if there are other patients in the family, if it's consanguineous marriage or not, and you look at the onset of the loss of fat, if it's early in life or later on. If it's early in life, most likely you are dealing with a congenital generalized libodystrophy or a familial type. And if it's a familial type, then you think of an autoimmune association. If it's a partial loss of fat loss, then you rule out localized lipodystrophy. And in the localized lipodystrophy, there are many diseases and acquired diseases. You need to rule them out. Once you rule that out, you look at the distribution of loss of fat, the onset, if it's early in life, if there is a family history, and if the fat loss is affecting the lower limbs, the limbs and the lower part of the body, you will think of familial partial lipodystrophy. If the fat loss developed at some point in life, and there are other in a cephalocaudal progression, and there are autoimmune feature, you will consider an acquired partial lipodystrophy. And I think this is not very complicated, but to make your life easier, a team in Spain developed an app in the Android or an iPhone. You can download it, called LipoDDX. LipoDDX, what it does, it takes you through this algorithm, and it will ask you certain question about your patient until you reach a definitive diagnosis. It's an accurate app, well studied, and we use it in our clinics when we have a case with lipodystrophy. It's good for pediatric and adult. So as I said before, there are 4 types of lipodystrophies: the congenital generalized, the acquired generalized, and then the familial partial and acquired partial. Under each one, there are certain subtypes with certain phenotypes, which I will talk in general about them. First, we'll talk about the generalized lipodystrophy, and then we'll talk about the partial lipodystrophy. So the generalized lipodystrophy, there are 2 categories: the congenital generalized lipodystrophy and the acquired generalized lipodystrophy. In the congenital type, there are 4 types of congenital generalized lipodystrophy. According to the gene mutation, there are 4 genes known. In the Gulf region, we have the congenital generalized lipodystrophy type 2 and type 4. This is what we usually see. In the acquired generalized lipodystrophy, you need to think of an autoimmune association panniculitis, and very often, sometimes we don't see a cause for the acquired generalized lipodystrophy. You need also to understand that generalized lipodystrophy is associated and overlap with other inherited syndrome, and you need to keep that in mind, like Candle syndrome, progeroid syndromes, and short syndromes. So if you have a case of generalized lipodystrophy, and the pattern of fat loss is generalized, you need to think also of an acquired type that we need to rule out. So you need to rule out malnutrition, anorexia nervosa, tumor-induced cachexia, and severe chronic inflammation, and endocrine involvement like thyrotoxicosis, adrenal insufficiency, and also HIV-associated wasting, because it's generalized. And this will go on because the list is also will go on because hyperinsulinemia can give an acromegaloid-like features on those patients. So you think of insulin receptor mutation, you think of acromegaly and gigantism. Also, polycontrolled diabetes can have generalized lipodystrophy, and also Dienkefeli syndrome. And I think to diagnose generalized lipodystrophy is not a difficult task, because the guideline now, it's clear. Most of the patients with generalized lipodystrophy, they have a significantly low leptin level and metabolic disturbances. So most often you will see a very high insulin requirement, more than 200 units per day, and more than 2 units per kilo per day in children. And they will require an adult even up to 300 or 400 units, and the diabetes will not be controlled. They also have severe hypertriglyceridemia, with a triglyceride above 500. It's really difficult to control these metabolic complications. Those patients also have a typical clinical picture: severe acanthosis nigricans. They often have PCOS. Sometimes they have also precocious puberty. They develop liver disease with NASH, early onset cardiomyopathy and hypertension, and also prominent muscles and prominent veins. They get also umbilical hernia. I'll show you a picture later on. And they have significant hyperphagia, worsening the metabolic complications. And worth to note that these patients early in life, in the first 2 years of life, they have failed to thrive, and then they become hyperphagic later on in life. Well, let's talk now about the partial lipodystrophy. So the familial partial lipodystrophy is characterized by partial loss of adipose tissue, and it's mainly affecting the lower limbs. This is when it's familial. And there are accumulation of adipose tissue in other parts of the body, such as the face and the neck. The pattern of fat loss usually are very heterogeneous in the familial. So they are the heterogeneous presentation in each patient have a different presentation depending on the gene. And in the acquired partial lipodystrophy, it's usually the adipose tissue is loss that happens later in life, and usually it does not present early in life, doesn't present occur. The adipose tissue loss usually follows a cephalocaudal pattern, and the first manifestation in the face, and then gradually progress downward, sparing the lower limb. That's in the partial lipodystrophy acquired type. So if you talk about the familial partial lipodystrophy, there are also certain types according to the gene, from type 1 to type 6. You also need to think in the partial lipodystrophy of progeroid disorders and other gene associated with the lipodystrophy, other known genes. And in the acquired partial lipodystrophy, when it's acquired, you think of an autoimmune phenomena, and oftenly they are associated with kidney involvement. So many patients develop membranoproliferative glomerulonephritis. The differential diagnosis of familial partial lipodystrophy is Cushing syndrome, truncal obesity, and Barker-Simon syndrome, progeroid syndrome. Myeloablative therapy can induce also lipodystrophy, and HIV associated also lipodystrophy can be also partial. If we talk about in detail about the certain common type of lipodystrophy, in the congenital type, Berardinelli and Sieb described this syndrome in 1954 and 1959. The congenital generalized lipodystrophy is an autosomal recessive disorder. It's basically in the type 2, there are two genes, PSCL1 and PSCL2. This is one gene but different locus, and they have nearly a complete lack of fat. The onset usually starts early in life, around birth or infancy, and they have prominent muscle, acanthosis nigricans, hepatomegaly, umbilical prominence, and verrucous appetite. There are multiple genetic causes for, and each one have a unique clinical feature, but most of them, they develop severe metabolic complications early in life. They also get severe cardiomyopathy and sometimes rectal disturbances. This is a similar, almost all the cases of the congenital type 2 have a similar phenotype. They are acromegaloid features with thick lips, thick nose, and severe acanthosis nigricans, and abdominal distension with severe hepatomegaly. In the familial partial lipodystrophy, it's usually autosomal dominant. The loss of fat usually affects the limbs, buttocks, and hips. And there are regional excess of fat in the face, and sometimes the patient will appear cushingoid. And usually they are normal early in life, and the loss of fat start around adolescent and puberty time. They also have muscle hypertrophy, and metabolic complications also can happen in adulthood. These patients also have increased risk of coronary heart disease and occasionally cardiomyopathy. In the acquired generalized lipodystrophy, what we call Lorentz syndrome, it's more common in female, 3 to 1. It usually appears before adolescent and may develop, but they might develop it later in life. And it progressive loss of fat affecting the whole body, and some fat will accumulate in the face and the neck or axilla. And metabolic complication in the acquired generalized lipodystrophy is also common because of the generalized loss of fat and low leptin level, and also associated with an autoimmune disease. When you look at this picture, you see that the patients are normal early in life, and then with time they develop severe generalized lipodystrophy. In the acquired partial lipodystrophy, what we call Barker-Simon syndrome, it's most commonly in female also. It usually begins in childhood or adolescent, and the loss of fat is craniocaudal. It starts at the head and it goes down, and it usually spares the lower limbs. So fat accumulates in the hips and the buttocks and the legs, and also associated with autoimmune disease, membranoproliferative glomerulonephritis, and they often have low complement level. But because it's only partial lipodystrophy, they have the metabolic complications are really not common in this disease. You see here a picture of an acquired partial lipodystrophy where She was normal early in life, and then with a progression over the years, you can see the face, there is a loss of fat in the face and in the upper part of the body, but sparing the lower limb. And this is very typical of acquired partial lipodystrophy. So what do we do when we have a child or an adult with lipodystrophy? You need to screen for complications and comorbidity. And this is around the metabolic syndrome, so diabetes, dyslipidemia, fatty liver disease. You need also to look at the cardiovascular carefully system. You measure the PP, you check for arrhythmias, and you do an echo for obstructive cardiomyopathy. You also have to rule out reproductive dysfunctions, kidney disease. Often they have proteinuria. Malignancy is not common, only in the acquired generalized lipodystrophy and progeroid syndrome. And there was a question at one time about leptin and malignancy, and it was later on found that leptin does not give you malignancy, but it's the disease itself. There are a high risk of not a high risk, but there is a risk of malignancy in the acquired generalized lipodystrophy. So there are major morbidity on those patients. It's usually around the metabolic syndrome, non-alcoholic fatty liver disease, and renal dysfunctions. And you can see here most of the organs are affected. They can also get diabetes early in life and high TGD. And if you look at the comorbidity and survival of these patients, most of them, if they have generalized type, they develop it early in life, while the partial type, they develop it later in life. They also get renal complications like end-stage renal disease in the generalized type, and they die because of usually cardiovascular events and hepatic involvement. Some of them, they die because of sepsis. Treatment is now available to those patients. In December 2015, an expert panel gathered together and they produced the guidelines. You have to understand that there is no cure to this disease, and we only give treatment to prevent complication and ameliorate the comorbidities. And the cornerstone of treatment is diet. And then we add other modality of treatment according to the condition of the patient. So diet, balanced diets in the severe form of lipodystrophy with metabolic complications. I think a very low-fat diet is extremely important. You have to be careful in the young children because of the importance of fat and brain development. Exercise with caution in cardiomyopathy cases, and metralleptin, of course, now is indicated, and treatment of other also complications. So metralleptin now is indicated for generalized lipodystrophy by most of the authorities. It's above the age of 2, but even they can some people started at the age of 6 months, and in the partial lipodystrophy above the age of 12 with a very high A1C level and TGD, it's also indicated. And here you can see the difference after 1 year of starting the treatment in the drop of hemoglobin A1C and triglyceride. And the treatment will continue, the efficacy will continue over almost 48 months without decline in the benefit of metralleptin. Also, patients on metralleptin were able to discontinue most of the medications they were on, like insulin, oral antidiabetics, and lipid-lowering therapies. And there were improvement in most of the organs in the body. It's well tolerated. They get only hypoglycemia, which you can reduce the dose. And sometimes they get weight decrease, but also you can reduce the dose. Most other side effects are really not common. This is the protocol, how we start the metralleptin in patients. So metralleptin is known to decrease the hyperphagia. Metralleptin will improve the fasting glucose level and A1C. It will lower the TGD. It will reduce the hepatic steatosis. It will decrease the proteinuria. Some of the patients, they deteriorate with proteinuria if they have renal disease, but it's only a minority, and you need to decrease the dose. And it also normalizes the gonadotropin levels. Our experience in Oman, we had 4 patients started on metralleptin, 2 of type 2 and 2 or 3 of type 4. One started almost 3 years ago. Sujud, this is Sujud, and Baylasan, her sister. They are typical of type 2. You can see Baylasan is an older sister. We couldn't start on her because of severe complication, liver cirrhosis. We opted to start in the younger one who have a mildly affected metabolic profile. We started her when her A1C was 6.6 with elevation of liver enzymes. And after sometimes, after a year of treatment, A1C improved, liver enzyme improved, and the metabolic profile became normal. So there were significant clinical improvement, improving acanthosis nigricans. The dose were adjusted according to her metabolic profile and significant biochemical improvement. This is her picture after a year of treatment. So the take-home messages from my presentation is that now the condition is, we are well aware of it. It's heterogeneous. The treatment option is also well documented, and we have metroliptin now available and well approved. We need to identify correctly the type, the subtype, and treat it accordingly. And we believe that the treatment will improve quality of life, will decrease comorbidity, and also will improve the prognosis. And I think metroliptin should not be denied for any patient if the financial resources permit. Thank you very much, Prof. Adnan.
Thank you very much, Dr. Saif. That was a very valuable presentation. The last speaker, we will keep the question till the end of the session, so please stay with us. The last speaker will be Prof. Khalid Hussein. He's a professor of Pediatrics in Weill Cornell Medicine, Qatar. Dr. Khalid is he was qualified from the University of Glasgow, Scotland, UK, and trained in neonatology, metabolic medicine, and endocrinology at Great Ormond Street Children's Hospital in London, UK, and also in Melbourne, Australia. He is currently working in Sidra Medicine in Qatar, and he is the division chief of pediatric endocrinology, and also he is the vice chair for research program and director of research children clinical management group in Sidra Medicine. His current research and interest focus on the epidemiology and molecular mechanism of childhood diabetes and early onset obesity in Qatar. Prof. Khalid has many and valuable research and publication in monogenic diabetes and neonatal diabetes and congenital hyperinsulinism. I consider Prof. Khalid Hussein as the expert reference for us in difficult cases of congenital hyperinsulinism and neonatal diabetes, and he will really give you a valuable and quick answer and advice whenever you emailed him. Dr. Khalid he's a great speaker in many of the national and international conferences, and really he contributed a lot to the ASPID academic activities over the last many years. Prof. Khalid Hussein presentation will be on monogenic obesity. Welcome, Prof. Khalid.
Good afternoon, everybody. My name is Khalid Hussein. I would like to thank the organizers of the Gulf Association of Endocrinology and Diabetes for allowing me to be part of this meeting. Over the next 25 minutes, I'm going to give you background to monogenic obesity. What I want to do is briefly give you an overview of childhood obesity, first of all, then start the introduction to monogenic obesity. I want to explain to you why it's important to make a diagnosis of monogenic obesity. I will then review some of the common causes of monogenic obesity. I will explain why having a molecular diagnosis can help in precision medicine and treatment for these children with monogenic forms of obesity. And finally, I will show you some of the work we're doing on monogenic obesity in early childhood at Sidra Medicine. You're all very familiar with the facts on this slide. We know that childhood obesity is becoming an epidemic all over the world. Obesity seems to be an interplay between factors which regulate genetic factors and environmental factors. And evidence suggests that early life events contribute to increased risk of obesity. And what is disturbing is that obese children will become obese adults. We know that there's an increased risk of type 2 diabetes, and this leads to increased risk of early complications. Now, I used to think that obesity is a simple equation of calories in and calories out. However, this is much more complicated. It's not as simple as this. So let's start by looking at what regulates your appetite. Several different factors are important in regulation of appetite. For example, hormones such as ghrelin, cholecystokinin, GIP, GLP, PYY, insulin, and of course, leptin. As you can see, these are produced from different organs, and they impinge upon certain areas in the brain which regulate appetite. And we'll go through this in a bit more detail in the next few slides. Apart from all those factors that I just explained, these are some other regulators of appetite. So these, on this side, this is appetite stimulation pathway. On this side, appetite suppressant pathway. And you notice, for example, a GUT-related protein, which we'll come back to later, becomes very important in terms of appetite stimulation. GABA, neuropeptide Y, and oxorelins and hypocretinins. Whereas on this side, you've got things like cocaine and amphetamine regulated transcript, melanocortin receptors, MC3R, MC4R. These become very important. As such, alpha MSH and POMC. Now, this is a very simplified cartoon model showing the leptin melanocortin pathway. We'll go through this in the next slide in more detail. So leptin is a key factor which regulates the two very important subset of neurons, the POMC neurons and the neuropeptide Y neurons located in the arcuate nucleus of the hypothalamus. POMC neurons, they produce alpha MSH, which then impinges on this MC4R and regulates important principles of appetite regulation. The neuropeptide Y neurons, they produce a GUT-related protein, and this is inhibitory on the MC4R and therefore inhibits appetite. So this is a very simplified cartoon model of appetite regulation. But then just look this again in more detail. Here's your different neurons, your POMC neurons here. This is leptin again, leptin acting through its receptor, leptin R here. And POMC neurons, they produce alpha MSH, which acts to inhibit food intake. You can see the key role of the MC4R here again. Whereas the GUT-related protein neurons here, they encourage food intake. So it's very important to keep this in mind as we discuss the different causes of monogenic obesity, because you'll see some of the very important receptors and proteins here, very important role in monogenic forms of obesity. So let's just go back to childhood obesity. We know that some of the endocrine causes are relatively rare. And if you have a child with endocrine cause obesity, you get attenuation of growth patterns. So the Endocrine Society recommends that genetic screening for rare forms of obesity is indicated only in the presence of specific historical or physical features. So one of the key things that we have to do in the clinic when we see a child with early onset obesity, we have to try and differentiate, is this monogenic, is this simple obesity, or is this pathological obesity? And we know that the endocrine causes of obesity are relatively few. These include, for example, Cushing syndrome, hypothyroidism, polycystic ovarian syndrome, and pseudohyperparathyroidism. So relatively few causes from the endocrine point of view. Now, this is a sort of conundrum you faced in the clinic when you see an obese child. The simple question is it simple or pathological? If it's simple, there's not much that can be done at early stage. If it's pathological, you'll need to investigate these children and try and understand the underlying molecular cause. Because as you'll see, there are now new treatments available for some forms of monogenic obesity. So monogenic obesity usually means that the obesity is caused by a single gene disorder, primarily located in the pathway that I've showed you, the melanocortin and leptin pathway. There are quite a few syndromes that are associated with obesity, and we'll show you a few of those syndromes. And of course, polygenic obesity is the most common form of obesity that you see in the clinic. Now let's focus on these monogenic causes of childhood obesity. So when you see a child in the clinic, what are the clues? What are the important clues that you might get that might alert you to the fact that the child may have a monogenic obesity disorder? I'll just list some of these important clues. For example, the obesity may start before the age of 5, and it's known that if children develop early onset obesity, that's usually before 5, you're likely to find a monogenic obesity condition. Hyperphagia, developmental delay, behavioral problems. For example, there's quite a few, there's several monogenic disorders of obesity that are linked with autistic features. Family history of early onset obesity. And you may find syndromic features on examination. So it's very important to take a very detailed history, examination, and try and understand if these are clues to a monogenic form of obesity. Now this slide just summarizes the differences between monogenic and polygenic obesity. So monogenic obesity is relatively rare. you're more likely to have a single gene disorder, large genetic effect, high genetic contribution, and very little environmental influence compared to the polygenic forms of obesity. Now here I've just summarized some of the common syndromes and some of the monogenic forms of obesity. For example, you're all aware of Prader-Willi syndrome. This is the hereditary Albright osteodystrophy. SIM1 is a monogenic disorder of obesity associated with hyperphagia and autonomic disturbance and autistic behavior. This one is another BDNF, another hyperactivity disorder with the impaired short-term memory and pain sensation. And again, these are, again, a syndrome you're probably all aware of is Bardet-Biedl syndrome. This is the syndrome associated with retinal dystrophy or pigmentation and renal abnormalities. And then if we go into the next slide, here you'll come to see some of the more common monogenic forms of obesity. So we're going to discuss MC4R in a bit more detail because this is one of the commonest forms of monogenic obesity. We are more familiar with leptin deficiency, for example. This is early onset hyperphagia with hypogonadism and mild hypothyroidism, leptin receptor, POMC we'll discuss in a minute, and PCSK1 where there's an association of obesity with small bowel enteropathy, endocrine disturbance such as hypoglycemia, hypothyroidism, and diabetes insipidus. So this is just some of the common monogenic forms. There are a few others. We wanted time to discuss those. So I like this slide because this summarizes the historical discovery of the different monogenic leptin genes. So you can see in 1994, the leptin was cloned, and the first leptin mutations were identified in 1997. And the most recent is the ADCY3 mutations, which also cause monogenic obesity. So let's just go through one of the commonest causes of monogenic obesity in a bit more detail, because as you'll see later, there are now new forms of treatment which are targeting the MC4R receptor. Mutations in MC4R are the commonest causes of monogenic obesity, and in the literature, this varies between 2 to 6%. These mutations can be heterozygous or homozygous. These children tend to be stocky built, have early onset obesity. And very interestingly, children with MC4R mutations tend to show preference for food which has a high fat content. So biochemically, these patients tend to have fasting hyperinsulinemia, but interestingly, they don't have diabetes. They have an accelerated linear growth. And then if you look at the growth hormone, the increased growth is accompanied by impaired growth hormone secretion with increased pulsatility and increased total growth hormone secretion. They have decreased prevalence of hypertension and reduced activity of the sympathetic nervous system. Now I'm just going to on this cartoon show the key role of the MC4R receptor again. So you can see that the POMC neurons and the agouti-related peptide and neuropeptide Y, they all impinge on the MC4R receptor. And this is then integral in regulating satiety, energy balance, and some sympathetic output. So just bear that in mind when we discuss some of the new treatments that are coming along. It's now very important to identify which child has a monogenic cause of obesity, because as I've said before, new treatments are coming along which can target some of the key proteins that I showed you, which are involved in the pathway of monogenic obesity causes. So therapies are now coming along. We'll discuss this now. First, you're all familiar with leptin and severe obesity. Leptin is a key satiety regulator of food intake. And you've seen these figures before. So leptin treatment can lead to a significant reduction in weight gain. And this has already been published and shown. And of course, then there's leptin receptor mutations, which also cause early onset obesity. But until recently, there's no treatment for patients with leptin receptor mutations. And as I'll show you in a minute, there's now new forms of treatment for this condition. Another very interesting condition is POMC. So this is pro-promymellocortin deficiency in severe obesity. Now what is POMC? POMC is a prohormone, you can see here. It's then cleaved at the level of the pituitary into ACTH, endorphins, and these fragments here. The ACTH then gets cleaved into in other non-pituitary tissues into alpha MSH. And this is very important to remember what this does. So this is important in pigmentation, immune response, and reducing food intake. So again, just showing you this in a bit more detail, the different fragments of POMC. This is MCH, the alpha melanocyte stimulating hormone, acting via the MC4R to regulate food intake. Here, the alpha MSH is acting via MC1 to control pigmentation, and the ACTH that's produced is acting via the MC2R receptor to regulate the production of glucocorticoids. So if the POMC is missing, then you cannot activate the MC4R, you cannot activate MC1 or the MC2R. So these were the first patients described in 1998. The first patient was a heterozygote mutation, and the patient number 2 was a homozygous mutation. And you can see the weight gain of these patients here. One of the patients had red hair because of the lack of melanin, but not all patients have been reported with red hair. These patients also had ACTH deficiency and therefore adrenal insufficiency with early onset obesity. So in 2016, an MC4 agonist called setmelanotide were used to treat these 2 patients with POMC deficiency. I'm just showing you here, so this was the weight of the 2 patients pre-treatment here, and this is the weight of the patients during treatment. So significant improvement in weight reduction in response to treatment with setmelanotide. And of course, the hunger score was also significantly impacted by this treatment. So it was very important to understand the mechanism of here, what was happening. So this setmelanotide was targeting the MC4R receptor in this leptin melanocortin pathway. The setmelanotide appeared to reverse some of the hyperphagia that these patients had, and led to impressive weight loss with normalization of insulin resistance. And both patients reported dramatic improvement in quality of life after the initiation of setmelanotide. And this is just looking at the action of setmelanotide in a bit more detail. So this is a normal hunger score here. So here you have your MC4Rs working under normal conditions, regulating satiety, ACTH being produced normally, and cortisol. Here, where there's a defect in the POMC, here the MC4 receptors are not working. So these patients are hyperphagic, and of course, cortisol is not being produced, so they need hydrocortisone. When you give setmelanotide acts via the MC4R receptor here, so it regulates the satiety, so it controls the appetite. But of course, you will still need cortisol in these children, because the setmelanotide doesn't act on the MC2R receptor. So after the description of those 2 children, it was hypothesized that maybe the setmelanotide could be used to treat other patients with other with other forms of monogenic obesity. And I'm going to show you the next few slides. This is exactly what's been happening. So it was thought that maybe children with the PCSK1, or children with the leptin receptor, or children with Prader-Willi syndrome might be treated with setmelanotide. So this was published only recently, where children with the leptin receptor mutation and again POMC deficiency were treated with setmelanotide. And this is just a summary of the slide of the study. So the results suggested that long-term use of setmelanotide for the treatment of obesity and hyperphagia caused by POMC and leptin receptor deficiency was effective. So these children lost significant amounts of weight, and also the hyperphagia was controlled. So it's going to show a few results here. So here, body weight, these are the patients with POMC deficiency. These are patients with leptin receptor deficiency. You can see this is baseline. This is approximately 1 year after treatment. So from 115 kilos to 83 kilos. So quite significant reduction in weight. And here, 131 kilos to 115 kilos. So significant reduction in weight for both of them. Here you're looking at non-bone lean mass and total mass. This is for POMC again, and this is for the leptin receptor deficiency patients. And then just looking at some of the metabolites in terms of glucose, insulin, lipids. So the patients with POMC deficiency, a significant reduction in fasting glucose. The HbA1c was slightly reduced. In terms of looking at the patients with leptin receptor, there was no significant change in the blood glucose or the HbA1c. In terms of lipids, in fact, for HDL, there was an increase here, but again, nothing significant. HDL cholesterol was similar. Triglycerides were significantly reduced here for children with POMC. And this is again comparing children with leptin receptor in terms of HDL, LDL, and triglycerides. And this is just again looking at the weight changes over time. And the red is a composite weight. So this is over time. And this is mean percentage change in body weight. So you can see quite a significant reduction of the children with POMC and significant reductions of weight for the children with leptin receptor mutations. Now these children have been followed up, and interestingly, it's been shown that the treatment with setmelanotide induces skin and hair pigmentation in these patients. But important to note that there was no malignant changes observed in these patients in the study. But this highlights the fact that these children need to be followed up with regular skin examinations before and during the treatment with setmelanotide. Now, there are other new treatments for monogenic obesity. For example, the GLP-1 receptor, liraglutide, has been successfully used for one form of monogenic obesity. Again, this is the MC4R. This was a paper published showing that liraglutide was successful in treating a group of patients with MC4R. And interestingly, it was shown that it wasn't specific for MC4R. Other patients with non-MC4R also lost weight. So it's not targeting the MC4R, but it's a general treatment for obesity in this cohort. Now, what about bariatric surgery? The debate about bariatric surgery goes on. The recommendations from the Endocrine Society are that bariatric surgery should only be used in those children in extreme circumstances. Not all patients with monogenic obesity should undergo bariatric surgery. So these are the recommendations from the Endocrine Society, but in the literature, there are now more and more case reports of children with monogenic obesity having bariatric surgery. Now, this is the latest review that I came across, just published in 2020, which looks at the outcome of bariatric surgery for monogenic, non-syndromic, and syndromic obesity disorders. And I've just summarized here a paragraph of what they've said. So there is limited evidence in support of bariatric surgery as a treatment for genetic obesity disorders. So no strong statement can be made regarding the efficacy and safety of these procedures. However, what they believe is that bariatric surgery should be considered as a last resort option in some patients. In my own experience working here in Surgery Medicine, we have some very patients with severe forms of obesity due to monogenic disorders. And despite all the different treatments that are outlined, nothing at the moment seems to be affecting these children. And I'm personally thinking whether we should refer these children for bariatric surgery. But we can discuss this during question time. I now want to just spend a few minutes just showing you a project that we've started in CIDRA, where we want to discover the genetics of early onset obesity in children in Qatar. And this sort of project has never been done in Qatar before. So what we do is we identify every child that comes to the outpatient clinic with obesity who's below 5 years of age. We do clinical, full routine clinical and biochemical workup. We use firstly an extended gene panel to identify the known causes of monogenic obesity. And the ones where we don't find anything, we then do either whole genome or whole exome to try and look for other causes. So amazingly, so far we've identified 145 children below the age of 5 who have early onset monogenic obesity. We've done the gene panel for 68 of these so far, and I'll discuss the positive results in a minute with you. And we're waiting for the gene panel in 77 of these children. So what we want to do, those that are going to be negative for both groups, we're going to do whole genome sequencing in those. This is just showing you the age distribution of those 145 children. Incredibly, we've got 45 children where the obesity started within the first 12 months of life. And then 16, just 2 years, 25 for 3, and etc. until 5 years of age. Now the extended gene panel is listed here. I'm just highlighting the common genes that we look for, that we're interested in, the leptin, the MC4R, the POMC, KSR2, etc. But this is the whole panel that we screen for. Some of So the common ones I've shown, that there are some other rare ones on there. There are also genes on there that are predisposing genes to obesity. There are also the syndromes, the Alström syndrome, for example, the Bardet-Biedl, the GNAS mutations in hereditary osteodystrophy. And also this panel looks for copy number variants. So quite an extended panel for the known causes of monogenic obesity and genes which predispose to obesity. Now these are results so far. I'm going to show you some of the positive ones in a minute. We've got a large number of patients with this variants of unknown significance. So these still need work. And of course, we've got some here where there are no causes found so far. So these are the results so far that are positive. So the most common gene that we found was the MC4R. And of course, and then we found the POMC, we found KSR2, BDNF, and some of the other genes. So it's a spectrum of findings, but the most common one, as found in other studies, was the MC4R. And I just want to give you an example of precision medicine with one of our patients where we found leptin mutations. So this was a young Qatari girl who came to our clinic, and she started gaining weight at the age of 3 months, rapid onset of weight, severe food-seeking behavior, and severe weight gain. At the age of 19 months, she weighed nearly 24 kilograms. This is a family pedigree, so both parents consanguineous. And she's got 3 aunties, who I'll show you later, also have significant weight gain, but 2 aunties that are otherwise well and healthy. So this is a child's weight gain. So this is the age. You can see rapid onset of weight just after birth. And this is just a graph illustrating the weight gain pattern. So what we found in this child, we found a novel exonic leptin gene mutation. And interestingly, normally leptin gene mutations lead to very low leptin levels. In our case, the leptin concentration was significantly high compared to reference. So the question was, why is the serum leptin level high in a patient who has an exonic leptin gene mutation? To cut a very long story short, the function analysis has shown that the mutation leads to a secreted leptin protein, which is not biologically active. So it does bind partially to the leptin receptor, but does not completely activate the leptin receptor. And we think the mechanism of the disease involves either triggering or negligible signaling by the leptin receptors as a competitive antagonist. And this suggests this is a novel mechanism of obesity. So this data is not published yet, but hopefully will be published soon. So what we did with this child, we then started this child on leptin treatment. And this is just showing you the protocols of the dose that we used and what we did on day 1, day 2, and for the first 4 weeks, and some of the blood samples that we took. We had to increase the leptin dose on day 3. So on day around 4 to 5, we observed a reduction in appetite. We needed relatively high doses, I assume because this is a competitive antagonism. There was no side effects reported by the family. The child did have significant V's before treatment, I assume because of obesity, but now the V's completely gone away. So we kept a food diary, observation of food-seeking behavior, and regular review in clinics for routine blood tests and weight measurements. And incredibly, after 6 months of treatment, this was the child's weight. I mean, when I saw her last in the clinic, she was 16 kilos, and complete transformation in a physical being and her obesity-related V's and mobility. So this is again just showing you the significant reduction in her weight from metroleptin treatment. Now going back to the family history, I mentioned that she had the child had 3 aunties, and these aunties are shown in red here. This is the weight of the aunties. So this auntie was 128 kilograms, this auntie 130, this auntie 108. All 3 aunties have the same mutation as the child. So this auntie we've now started treatment on, this auntie. She's been started in the same protocol as the child, and she's now down to 110 kilos. She lost 20 kilos in the last 4 months. So very interesting observation on this family. And this auntie who is not affected has a normal weight of 57 kilos. So just want to leave you with a few key take-home messages. It's important for us physicians to distinguish between simple and pathological obesity, or monogenic obesity, I should say. Monogenic obesity is now amenable to treatment. There are now drugs coming along, drugs which are already present and new drugs which are being developed to treat monogenic obesity. And this is where precision medicine becomes very important. As I've shown you, leptin for leptin gene mutations, setmelanotide for example, POMC or leptin receptor, and possibly other monogenic forms of obesity can now be treated. So effective therapy is now coming along, and this is extremely important for the future. In terms of bariatric surgery, I think this is still out for debate, and the current recommendation is that this should not be undertaken unless there are extreme cases of obesity which do not respond to medical treatment. I want to thank again the organizers of the committee for allowing me to be part of this presentation. Thank you so much.
Thank you, Prof. Khalid. That was very valuable and interesting presentation, very beneficial. I think we extended the time for the presentation, so we will have only 3 minutes for the question. So let me start with the first question to Prof. Khalid. The question saying, Dr. Khalid, very interesting presentation from Karen, and she's saying, have you have any information on the rebound effect when treatment is interrupted?
If you interrupt treatment, they'll start gaining weight. It's been shown in the patients with leptin deficiency that if you stop treatment, they start gaining weight again. I suspect the same will happen with the other monogenic disorders, the leptin receptor, for example, and the POMC. So the same thing, if you stop treatment, they'll gain weight.
Okay, and a question for Dr. Abdulhadi. Very nice talk. In your last presented case, did you test the parents who reported they did not have diabetes?
That's a very good question, because I think the person who asked the question talking about the child with GCK mutation or MODY2. And the simple answer is yes, biochemically, none of them have evidence of diabetes. They both have normal A1C and they have no symptoms of diabetes. We were interested in looking into the GCK mutation in the mother because she had a history of gestational diabetes, and we know GCK mutation can present or can be misdiagnosed as gestational diabetes. But the good news is she didn't really have this mutation when we tested. We didn't test the father. We didn't go through the both family, but clinically and biochemically, there is no evidence of diabetes.
Great. Thank you, Dr. Abdulhadi. Very good answer. The question again for Prof. Khalid. One of the attendants is asking, he's asking about a case. I have a patient with MC4R, obesity reaching currently a BMI of 76, very huge, post-menarche. He's saying 76 maybe kg per meter square, so it's supposed to be right numbers. His question, do you think starting liraglutide going really to make a difference, or a bariatric surgery better at this level of obesity?
I would give a trial of 6 months of liraglutide. If it doesn't work, I think this is the sort of patient we need to think about bariatric surgery, because I think this is severe extreme obesity. The patient probably will benefit, but may gain weight later on after bariatric surgery. So he may buy time for a few years. But I would definitely try liraglutide first of all.
Can I ask Khalid, Prof. Adnan, can I ask Khalid about MC4? Prof. Khalid, I had a few patients with MC4 mutations, and before the era of liraglutide. And because of the severe morbidly obese phenotype, I did bariatric surgery for them.
Okay.
And after about a year or so, they regained the weight.
Yes,
but
absolutely.
I bought sometimes for a year or two, they lost 20 to 30 kilos with bariatric surgery, but they're regaining the weight. So I agree totally with you. You buy time with them.
Absolutely. This is what you can do until the new treatment specifically for Mc4 receptors designed. Absolutely.
Thank you.
It seems a lot of questions on monogenic obesity.
We need a full session on monogenic.
So another two questions, Khalid, Prof. Khalid. The question for you would say, what clinical features in children with obesity increase the yield of genetic testing, likelihood of finding a pathological variant? Thank you.
So in one of my slides, I highlighted the sort of examination and the clinical features like early onset obesity before 5, severe hyperphagia, severe food seeking, developmental delay, possibly autistic features, or anything syndromic on examination. Those things should alert you to the possible early onset obesity, but especially if the obesity starts before 5 years of age. That's a very, very important marker of possible pathogenic obesity or monogenic obesity, I should say.
Another question for you, Prof. Khalid. Say if I have a patient below 5 years with obesity and I don't have a genetic testing facility for diagnosis, what should I do regarding the treatment or the diagnosis for those patients?
Unfortunately, you cannot treat until you know the molecular mechanism, like I explained. So I would ask the person to collaborate with somebody in their country to do the genetic testing for them. You cannot treat blindly these children because you don't know what the mechanism is.
Great. And I have a question for Dr. Saif Al-Yaroubi. Do we have local published data on generalized lipodystrophy or localized lipodystrophy in the Gulf region?
We had a paper in 2004 by Anna Rajab, and she described a significant number of patients at that time, around 14 cases in Oman only, and mainly type 2 and type 4. And from my talking with my colleagues in the Gulf, each one have a few patients. So yeah, we need to do a registry for our patients in the Gulf, but yeah, we have a significant number. The published data is really scanty and very little.
Great. Because of the time, we will have only the last question for Dr. Abdulhadi Habib. Do we have a prevalence data for the Gulf and Saudi Arabia on monogenic diabetes, specifically on MODY?
Well, the simple answer is no. There are a couple of, or maybe a few case reports and family reported here and there, but I'm not aware of any robust data on the prevalence or incidence of MODY or any other forms of monogenic diabetes, of course, apart from neonatal diabetes.
Can I make a quick comment? Can I make a quick comment?
Go ahead.
We've now got all the data on MODY for Qatar. It's now published for type 1, type 2, all the different types of diabetes now completely published for Qatar. So Abdulhadi, review the literature, please.
Yeah, thank you very much.
Diabetes.
Great. Prof. Khalid enriched really our region with the research, and hopefully we will get, inshallah, these data available for most of us. The last question for Dr. Karen, the age cut in our country or in our region is about 14. Some Gulf region will manage pediatric diabetes till 15. How about you, and how you are dealing with this difficulty in this age?
I think it's a very early age. So if you want to have a transition, you really have to develop very close collaboration between pediatric and adult teams, because it's in the middle of the adolescent development. For us, we have changed our approach, and we now propose between 18 and 25, the time young people in generally get more mature and take a different kind of approach to their diabetes. So I think 14 to 16 is something within ISPAD at a global level we would less endorse. And if it is something which belongs to the region, I would really advise to have an incredible good collaboration between pediatrics so that we get the kind of adolescent, either internal medicine or adolescent healthcare provider at the pediatric side.
Great answer. I think we have to conclude. Very interesting session and a lot of questions specifically on obesity and monogenic obesity. Obviously, we have a major problem of obesity in the Gulf region. I would like, on behalf of the all the attendees, to thank the speakers. It was a very, very valuable session. We enjoyed all the 4 sessions. Thank you very much, Dr. Karen. Thank you, Abdulhadi. And thank you, Prof. Khalid. And thank you, Saif. It was a great session. Thank you very much. We'll see you soon in physical meetings soon, inshallah. Thank you.
Thank you very much.